But it's now my pleasure to welcome Professor Anna Ranta to present on her study that she's done on the neurological workforce. Professor Ranta is a Wellington-based academic neurologist with extensive neurology leadership and leadership experience. She is currently the leading neurologist and researcher at Otago University. Prior to this, she held senior academic and leadership roles. Her research focused on translational research to optimise stroke and neurology care quality and access, with a strong emphasis on addressing health inequities. So, Professor Ranta, if you would like to come up.
Kia ora koutou, ko Anna Ranta tōku ingoa. Thank you for coming along today, and thanks for the invitation to speak. So I'll talk about the neurology workforce. Here are my conflicts of interest or potential conflicts of interest. I get some funding for research, but I don't get any industry funding, and I don't have a private practice. So I just want to mention that I have no personal gain that I can get financially from anything that I'm talking about today. Not that people in private practice do, but you might wonder. So I'm going to talk about briefly what neurologists do, and most of you know that deal with MS, but there's a couple other things we do as well. I'll talk about the current situation with the neurology supply in New Zealand. I'm going to talk about what the demand is and what the gap is between supply and demand. We'll compare where we're at with other countries around the globe and talk about a little bit about the modeling we've done as to what the future will hold if current trends continue and what we could do to address any gaps in demand versus supply, what the implications are, and then some solutions. So what do neurologists do? Neurologists primarily support brain health. They prevent, diagnose, and treat conditions that affect the brain, but also the spinal cord, the nerves, and the muscles. So the nervous system is quite large. Common neurological conditions include MS, that we've heard about, but also stroke, epilepsy, headache, Alzheimer's disease, Parkinson's disease, neuropathy, meningitis, muscular dystrophy, and many others. The brain is pretty complex and arguably the most complicated organ in our bodies. And it takes about 15 years to train a neurologist from the time they leave high school. And neurological disease is very, very common. It's disabling and reduces life expectancy. Neurological diseases are the leading causes of ill health and disability globally, and the second leading cause of death globally. 22% of hospitalizations are because of neurological causes. So, I'll be talking about some data from a study that we conducted. It was based on surveys that we did of individual neurologists in New Zealand, as well as unit heads, to get more sort of a team-based approach view of things. And when I talk about neurologists, it's sort of a surrogate for the whole neurology team. So the neurology team, as we heard, has more than just neurologists, doctors. It's also nurses, physiotherapists, physiologists, a number of people. But we looked at the neurologist as sort of the main unit, but we're talking about the whole team. We cross-validated with other data from the Royal Australasian College of Physicians, New Zealand health data, and then we modeled productivity, looking at supply as to how many people, but also how productive are neurologists and what are the trends over time. And then how does that compare with demand? And how do you assess demand? You look at things like disease incidence and models of care, and I'll talk about that a little bit more. So here is the individual survey results. So these are the neurologists. These are not all neurologists, but they are the 54 neurologists, which is a pretty high number of the people in New Zealand that responded to the survey. So firstly, the average age of neurologists is 52, which is very, very young. It's not personal. And it's now gender. We have 33% of us are women. In 2014, 23% were women, so we're doing better, but we're still short of population and we're not representing New Zealand population. And the same can be said around ethnicity. Yes, we do have a couple Maori neurologists. We don't have any Pacific neurologists. We have a fair number of Asian origin neurologists, but we don't reflect the population yet. And we know that doctors that reflect the population achieve better outcomes for their patients. So we have some work to do. Where do neurologists primarily work? Unsurprisingly, most of us work in the big cities. And where do we come from? So most of us have trained in New Zealand, and people like myself, as you can tell, have trained overseas. So a lot of people do come from overseas, but it is important to remember that most of us definitely train in New Zealand, and it does give an extra perspective if you train in the country that you're caring for. And we heard earlier that overseas trainees are cheaper for the system, but are they? I've been here for 20 years, so I consider myself a bit of a Kiwi, and I think I've learned a lot about the system. But people from overseas come and go, and there's often a churn, and there's a cost that comes with that. And then what kind of subspecialty interest people have that are neurologists? So primarily, actually, it's MS, which is great for people with MS, but we need more people with interest in MS and also more people with interest in other neurological conditions. So looking at the current workforce, so I'm talking about full-time equivalence here, which is somebody working a 40-hour work week, which isn't the same as headcount. Right? You can have more people who are neurologists, but if they work part-time, it's not like having a full-time neurologist. So we have 67.3 full-time neurologists, or FTE, and that equates to 83 individuals, so you can see a large number work part-time, and 8 of those are pediatric neurologists, and 6.4 work in private, leaving 52.6 working in the public sector. This is the number that was talked about earlier, the per population number, and it depends a little bit how you present it. So roughly 1 in 75,000 neurologists. So for every 75,000 people, we have 1 neurologist, 1 in 89,000 adult neurology, 1 in 99,000 in the public sector, where almost everyone with MS is managed. And then we have a metro to non-metro disparity. So not only do we have numerically more people in city, it's also not compensatory, it's not appropriate for the number of people living there. So we have more people in the metro area, meaning the people living in rural areas are relatively underserved. Now, how does it compare internationally? And I apologize, this is a slightly different way of looking at it. So we looked at neurologists per population. This is the number of neurologists per 100,000 people. So here we want the higher the number, the better. So we in New Zealand have 1.3 neurologists per 100,000 people. In Australia, they have 2.8. In Europe, they have 6.6. And cardiology in New Zealand has 3.3, so almost 3 times as many as neurologists. The horror. Oh, here we go. Here we go. Here's another slide, and if you look at this, you see the big thing in Europe, so you might say, well, what about North America? You can see, I don't think I have a pointer. Oh, yeah, there. Kind of doesn't work on the screen. But if you look at the AMR, that's America, but that's South and North America. So when you filter, there's 23 countries in America, so the US is a very small bit of that if you look by country, if you look by average neurologists per country. So that number is pretty small. But if you look at New Zealand and Australia, we have 1.28. We're much closer to low and middle income countries around the globe. We're nowhere near other high-income countries. So you ask yourself, are we in a high-income country or are we actually in a low-middle-income country? So what I've talked about is in the red box, that's the supply of neurologists. We're now going to talk a little bit about the demand of neurologists. So I've told you how many we have. Maybe people have too many neurologists somewhere else, What do we actually need? So we've looked at that. And I have a bit of a complex slide here, and I don't have a great pointer, I don't have a mouse, but we'll see, I'll describe the lines. So work with me here for a second. So you see the black line at the bottom, so the little dotted, not quite a dotted, but a stringed line. That's the current supply of neurologists. So if you look at the left at the graph where you see 50, we're just around 60 neurologists. That's a number of neurologists. And over time, that will go up, as the trend has been going up over time, slightly, by one extra every year. The green, the bit with the bigger lines, the green line, the little strip and the dot, the strip and the dot, that is what we think the demand is for neurologists in New Zealand, taking into account the neurology model of care that we use in New Zealand. The dotted green line is what makes up the gap, how we will bridge that gap. Now, on the right-hand side, you see a legend. Ignore the red line for the moment. You can see that the line to bridge the gap, the dotted line, would require us to hire an extra 4.5 neurologists a year across the country. That doesn't sound like very much, does it? But currently, we only hire an extra 1.3. So we will not, that gap will widen. But if we were to hire 4.5, we would reach that goal. So that would be a good start. So what about that red line at the top? That's what Australians think they need to manage their neurology demand. So why do we need fewer neurologists in New Zealand? Are we healthier? Are we better? Are we different humans? And some of you might say, maybe we are. Mostly we're probably not. We're pretty similar to Australians. So what's the difference? So New Zealand operates in what we call a generalist model of care. Most hospitalized patients with neurological conditions do not see a neurologist and never see a neurologist. They mostly see general physicians. Key conditions like headache, and I talked to one of the general practitioners here earlier, is entirely managed in primary care, never sees a neurologist. Stroke, Alzheimer's, Parkinson's, and motor neuron disease is primarily seen by geriatricians. And then we have a focus on first specialist assessment. So that's the new patient, the diagnosis. The neurologist makes the diagnosis, but then never gets to see the patient back. So seeing a patient once a year for MS, we sometimes achieve that. Most people seeing a neurologist never get seen again. Some people get seen once. On average, people get seen only one time back. And so people get seen 6 times. There's 6 people who only ever see the neurologist once. So very limited follow-up. Our Australian colleagues believe you need 6 follow-ups per patient. We have 1 follow-up per each patient. And we believe that's entirely inadequate. And if you look at the nature of neurological disease, which are disabling and chronic, we need to follow these people over time, including some of you. So many patients never get the ongoing care they need. So, well, do they need it? Maybe it's okay for generalists to care. Maybe we just run a really efficient system here, and everyone else internationally could learn from us. And, potentially more cost-effective, more holistic care closer to home. But I just wanted to show you this. So this is a little chart, you can get people to fill in points. When I gave a lecture to GPs about the neurologic examination. And I asked them, what do you think when you think about the neurologic examination? Most of them said it's very time-consuming. Neurology is complicated. They also said it's essential and important. Others said it's challenging, it makes them nervous, it's complicated, it's scary, they feel dread, anxious, and overwhelmed. This is what GPs tell me they feel when a patient with a neurological condition walks into their practice. So, maybe it works for some things, but maybe it also doesn't. Neurological disease is complex. There's clear evidence that generalists feel overwhelmed, and people with neurological diseases are therefore at higher risk of suboptimal management. If you see something twice a year, it's not because specialists are smarter, but if we see something 30 times a month and a GP sees it twice a year, we will be better. We're just more experienced. This is does it actually impact outcomes? Here's a study that I ran a few years ago. This is stroke. I do primarily stroke, but if you look at the tertiary centers, the people who are independent after their stroke have died, have had recurrent stroke, recurrent vascular events. You can see that people managed at tertiary centers under the care of neurologists, where we have more neurologists, across the board have better outcomes. And there's a dose effect. The smaller the hospital, the worse the outcomes. If you can see that across all the way to the small rural hospital. And again, I admire the people in rural hospitals. They do an amazing job, but how can they be an expert in everything? So, maybe I've convinced you that maybe the Australians have it right. Maybe we should have even more neurologists than the current New Zealand model of care would predict. So I would challenge us to say, we need to get to that red line. If we want to get to that red line at the top, we need to hire an extra 12 neurologists every year, which is a huge task, but we need to start somewhere. Now you'd say, okay, well, this is what we always hear. It's like, oh, you got to just be more efficient. We don't have money. We don't want to hire more people. We need to be more efficient. Can we be more efficient? So we did a similar thing in 2014, and we said, you know what? Let's increase more nurses because nurses are cheaper, right? They also add a lot of care. We don't talk about that a lot. Nurses add amazing quality of care and patient experience, but the idea is, well, they're cheaper, so if we have more nurses, maybe we can have fewer doctors and save money because we don't have a lot of money. So can we increase efficiency by increasing nurses, developing pathways by pushing more into primary care, and developing fancy technology to replace the neurologist? Well, nurses have increased, we have more pathways, and more care has been shifted to the community. But productivity has reduced. 9% reduction in productivity over the last 10 years. So why might that be? Well, it probably did have an impact to hire more nurses, do pathways and various other things, but diseases have become more complex because people have multiple comorbidities, they're getting older, and we're getting all these amazing treatments, like MS treatments, which have changed MS. But they're complicated. They need extra special expertise. We need more nurses for the doctors. We definitely need to see people yearly. And so it increases the demand and cognitive load also for neurologists. And so, the patients get more complex. We have this, because we're shifting more to primary care, we see even more complex patients. We no longer see a patient who just needs a repeat prescription. Every patient is new. Every patient is a huge cognitive load, so it reduces productivity. So this idea that we just make everything more efficient by seeing everything in primary care, there are flow-on effects. And then we've seen this emergence of treatments in acute neurology, like in stroke. Stroke has become much more complicated, and we have all these amazing treatments that are really effective, but people with stroke don't just show up 9 to 5. They often show up in the middle of the night. And so we are all very exhausted because we need to see these patients overnight, and unscheduled nighttime work is inefficient. If we could get rid of sudden health problems, we'd have so much more money because we could plan for them. But sudden health problems are very inconvenient. We don't know when they come, we don't know how many people, often there's no pattern, so we have to have people in place to be ready for them, but it's not always the most efficient use of resource, so it reduces productivity. It also makes people more tired, and the next day are going to be less productive next day or might need some time off. Also, shifting things into the community means the GPs don't get our support anymore, so we get phone calls all the time to help GPs. That is disruptive to our workflow. It's not scheduled. It also reduces productivity. And to save money, we have fewer administrators, fewer supports in clinic, so we do more administrative work. So there's a number of reasons why our productivity has gone down. There's also changes in workforce patterns. Our younger doctors say, I want a weekend off. I want to have some time in the evenings with my family. I'm a young mother and I want to take care of my child, or I'm a young father. So there's a number of changes. These are good changes because we're valuing doctors and we're valuing that this is hard work. But we're not ready for this because we've, for many decades, relied on the goodwill of doctors working many, many more hours than they're paid for. So we need to account for that. So these are some factors that may be causing reduced productivity. But the bottom line is, we can increase efficiency, and we need to try to increase efficiency, but it's not enough. We need to increase neurologists. So what does all this mean? So in brief summary here, so New Zealand neurology workforce is increasing in diversity. We've got some more women, which is great, some different ethnicities, which is good, but we still have some work to do. Most importantly, New Zealand neurologist rate is very unfavorable compared with Australia, Europe, and cardiology. Projections suggest maintaining status quo will result in worsening of the problem. Current practice patterns probably do not meet our population's need, and the productivity is reducing because of the various things I've just discussed. So what can be done about it? Well, as I mentioned, to meet current New Zealand demand based on the New Zealand model of care, we need to triple the number of neurologists that we increase every year to achieve the Australian model, which is probably more appropriate and goes along with other high-income country modeling across the globe. We need to increase our yearly increase of neurologists 8-fold. So what can we do? We need to increase the hospital neurology consultant positions. So public hospital consultant positions need to increase to meet the demand and also to provide jobs for the people we train, because currently out of 4 to 5 people we train every year, only 1.3, that third of a person over 3 years, so 1.3 we can offer a job to. So imagine that. You go 15 years in your home country and then there's no job for you because we don't think we need more neurologists, yet we show there's so many more needed and so much more needed. So we need to increase neurology positions to attend to the trainees, but we also need to increase neurologists even further because that's only going to be to meet the New Zealand demand, not the actual demand. And so we need to also increase trainee posts to get more trainees through and concomitantly increase the neurologist consultant posts. We need to also be better able to attract neurologists to stay in New Zealand by offering pay and benefits and things that are somewhat commensurate to international. You know, we're pretty popular around the globe. It's hard going staying here, finding reasons to stay. You know, most of us love it here, and I've been here for 20 years, and I really love it here, and I'm probably not going anywhere. But, you know, it's understandable when a young person struggling to get a job has an offer of a salary that's 3 times as much somewhere else, even if it is in the United States, they might go. We need to, I feel like there's some feedback somewhere, but do you hear that? Was that my tinnitus? Oh, the bell. Yes, go off to govern. So we need to increase medical students. We need to prioritize workflow tools. There are things we can do to improve efficiency, but we cannot do it in isolation. And we need to honestly and seriously reconsider New Zealand models of care. Having worked in the US and in Germany and working globally all the time, our model is very, very old-fashioned. We operate in the UK model of 2000 or 1990. We need more specialists. Yes, we need more GPs, but we also need more specialists. We cannot have generalists manage everything, and they'll be the first to tell you. So the next steps. There's urgent action needed, and we need impactful action. So I think we need a national neurology workforce strategy. And that's something we're discussing amongst my colleagues in the Neurological Association of New Zealand and along with the Neurological Alliance that MS New Zealand is a member of. So we want to develop a strategy. It will be a more effective strategy if government lends its support or at least receives it and considers it when it's done. And then, as I was preparing the talk, I was wondering about national clinical networks. We have a cardiac network, we have a cancer network, we have a respiratory network, we have a kidney network. Kidney, respiratory, cancer, cardiac, you know, like there's a big disease groups. We do happen to have a stroke network, but stroke is just one small part of neurology. Why do we not have a brain network or a neurology network? Considering that 22% of hospitalizations are neurological, that's almost a quarter of all hospitalizations, and neurological diseases are the leading cause of ill health and disability and the second leading cause of death globally. This should be the highest priority in New Zealand. So I hope I've convinced you that we should work together to address this urgent and growing crisis and to help our people with neurological conditions. Thank you very much.
Yeah, thank you. Yeah. Oh, sorry. I don't feel I deserve this, but thank you very much. Sorry. I was just going to say that we've got a few minutes to spare before we go in for a break. So if people would like to ask questions from the floor, Anna has not been forewarned of this, but has kindly offered to stay up on the stage and answer questions. And I will actually, notwithstanding your conflicts of interest statement earlier, offer you a small gift of no monetary value whatsoever. But thank you.
Thank you
very much indeed. If we have questions from the floor, please do. Oh, I beg your pardon. Yes, thank you. There will be a Q&A at the end. Shall we leave it all to that? Leave it all to the end. Absolutely. This has been well rehearsed. Thank you very much. I think, therefore, we can break for a 15-minute break. There'll be some tea, coffee, light snacks at the back of the room. So thank you very much.